The first topic of this session is by Dr. Deepa MG, Associate Professor in Government Medical College, Ernakulam. Her topic is diabetic retinopathy, when to intervene.
Good morning. I'm Dr. Deepa, Associate Professor of Ophthalmology, Government Medical College, Ernakulam. Please pardon me for my voice because I've been down with a fever. Well, I'm talking about what are the situations in which we have to intervene or we have to treat in diabetic retinopathy. Compiling the data from various studies across the world, around 35 studies covering 25,000 people, it is seen that among those with diabetes, 35% has diabetic retinopathy, around 7% has PDR, the equal percentage has got a diabetic macular edema, and about 10% of people have vision-threatening complications of diabetic retinopathy. So this itself shows the importance of the right diagnosis and the right and timely management so that we can save vision as well as preserve the quality of life of many of diabetic retinopathy patients. So the relevance of the topic is quite obvious. The treatment options that we have is laser photocoagulation, intravitreal injections, pars plana vitrectomy, and medical management of diabetes, as well as the coexisting comorbidity conditions like hypertension, dyslipidemia, renal anomalies, etc. Coming to laser first, what are the indications for pan-retinal photocoagulation? As you all know, it is mainly proliferative diabetic retinopathy, low risk being an NVD less than 1/3 dis diameter, NVE less than half dis diameter, and high risk PDR where NVD is more than 1/3 dis diameter or NVE more than half dis diameter with vitreous or pre-retinal hemorrhage. And any NVD with vitreous or pre-retinal hemorrhage is an indication for PRP. In low-risk cases, sometimes, depending upon the severity of signs, systemic comorbidities, patient circumstances and all, you may wait for a PRP, but then ensure that the review is done strictly in 2 months. At the same time, in some other low-risk PDR patients with low compliance, pregnancy, systemic comorbidities, rubeosis, etc., we have to insist on a PRP. Another indication is diabetic macular edema, and the ICO classification goes like if there is no retinal thickening or hard exudates at the macula, there is no diabetic macular edema. When there is a thickening at the macula but not involving the central subfield area of 1 mm diameter, that is non-central DME, and if the central area is involved, that is central diabetic macular edema. The treatment options again are intravitreal anti-VEGF, laser photocoagulation, and intravitreal steroids. So in macular edema with no central involvement, we can wait, or we can apply a focal laser to the leaking microaneurysms if the thickening is encroaching or threatening onto the fovea. In DME with central involvement, the key factor that you have to see is the vision. If the vision is good, that is, if it is 6/9 or better, we have 3 options. We can observe, and then on reassessment, if it is worsening, we can give intravitreal anti-VEGF, or if the signs are severe enough, we can give intravitreal anti-VEGF straight away, and sometimes they may need a laser photocoagulation, combined therapy with anti-VEGF. If the diabetic macular edema with central involvement and visual acuity is less than 6/9, then definitely it should be treated with intravitreal anti-VEGF. Laser photocoagulation if it is persistent retinal thickening after 24 weeks also, and intravitreal triamcinolone alone can also be tried, especially in pseudophakic eyes. If the diabetic macular edema is associated with a proliferative diabetic retinopathy, intravitreal anti-VEGF, and consider repeat injections or PRP if it is not resolving on follow-up. If an associated epiretinal membrane or a vitreomacular attraction is present, a pars plana vitrectomy is advised. So we saw the indications, the general indications for laser, but sometimes in severe NPDR also we have to consider treatment. So what are the indications in severe NPDR? Especially in older patients with type 2 diabetes mellitus, when the patient is having a poor compliance or we have a difficulty in the evaluation of the fundus due to a very hazy retinal view, when the patient is preparing to undergo a cataract surgery, as the surgery itself can worsen the diabetic retinopathy, and if it is a one-eyed patient or the patient has already lost the vision in the other eye due to complications of diabetic retinopathy. So this in very brief are the indications for us to intervene, and the treatment options, the pros and cons of each of this will be explained by the coming speakers in the next coming sessions. Thank you all for your very patient listening.
Thank you, Dr. Deepa.